everyone. My name is Amisha. I use she, her, hers pronouns, and it is my privilege to serve as the Executive Director for UConn Global Health Spaces on campus. It is my pleasure to welcome all of you to our 4th annual Global Health Symposium, Decolonizing Global Health. For some of you, global health is a field that you have developed a strong passion for, while for many of you, this may be the first step of your global health journey. So what exactly is global health? When we think of global health, it is easy to initially think about it in a purely medical sense and an international context. It's easy to think about global health being someone volunteering overseas, helping someone far, far away in a remote village somewhere in Asia or Africa. However, the reality of the field of global health is much different and more complicated. Global health seeks to increase access to quality and affordable healthcare, regardless of individual background or personal circumstance. It looks to ensure that everyone has the same access to a quality healthcare system. Many of these disparities can be found right in our own backyard, with life expectancies differing by zip code and mortality rates varying by race. Global health does not happen in an isolated bubble. It's a complicated and diverse field, one that requires innovative and interdisciplinary solutions. The fight for a healthier world does not just rely on doctors. It calls upon engineers, lawyers, nurses, artists, policymakers, writers, and social entrepreneurs. It calls for technological innovation, legal and political support, a commitment to human rights, and an understanding of history, anthropology, sociology, and psychology. Global health is at the intersection of all of these fields. Regardless of professional or personal interest, everyone can make a difference in the field of global health. Global Health Spaces on Campus was established in 2018 by a group of passionate undergraduate students from many departments and schools at UConn, all united by a common goal to establish UConn as a global health center across the country. Since then, we have organized 3 annual global health conferences, Think Global Act Local 2018, Winning the Birth Lottery in 2019, and VIP Access Gatekeeping in Global Health in 2020, engaged hundreds of students and faculty in the global health conversation, networked with changemakers across the globe, and gained national and international recognition for organization and symposium. In our efforts to engage students and professionals from all disciplines in global health changemaking, we established an annual global health hackathon, where for 2 years in a row, students from all academic and pre-professional interests have come together to solve solutions to the world's most pressing global health issues. Of course, all of this would not be possible without the help of our generous sponsors and partners. I would like to thank Global Affairs, the Human Rights Institute, Dodd Impact, and the Research Program in Global Health and Human Rights, along with the College of Liberal Arts and Sciences, the UConn Sociology Department, UConn Anthropology Department, and the UConn Individualized and Interdisciplinary Studies Program. I would also like to thank the countless student organizations and departments both here at UConn and across the country that shared this event with their students. And of course, a huge thank you to my friends in UConn Global Health Spaces on campus who have worked tirelessly over the last few months to make this weekend's programming a reality. This year's symposium, themed Decolonizing Global Health, seeks to explore the historical and political realities that underpin the healthcare system. Further, we invite you to question how these forces shape the reality of healthcare systems at home and abroad. Colonialism is not a relic of the past. In many ways, colonial structures still define the relationship between countries in the global north and global south. It frames the global health conversation in such a way that places more power in countries traditionally defined as developed at the expense of countries deemed underdeveloped. The COVID-19 pandemic has lifted a lid on the ugly underside of these systems. They have demonstrated the vast inequities in access to quality, sustainable healthcare, as clearly demonstrated currently in the asymmetric vaccine distribution system in countries across the globe. As we discuss decolonization this weekend, we must remember that this is not a conversation about just other countries and areas around the world. Rather, the impacts and long-lasting effects of colonialism can be found in the United States, with our history of colonizing Native American and Indigenous lands. Thus, before we start our event today, we would like to begin by acknowledging the Mohegan, Mashantucket Pequot, Eastern Pequot, Schaghticoke, Golden Hill Pagussit, Lenape, and Nipmuc peoples whose traditional lands we currently stand on. We recognize and respect Indigenous peoples as traditional stewards of this land and the enduring relationship that exists between Indigenous peoples and the land. It is also worth noting that the town of Mansfield, and by extension, the University of Connecticut's existence and legacy, would not be possible without the labor of enslaved Black people. We acknowledge, respect, and honor those whose forced labor allows us to work, live, and learn in this space. Over the course of today, we will explore the concept of decolonization and its influence on healthcare, health outcomes, and much, much more. This evening, we will hear a keynote from Dr. Nichole Starr, who will present what decolonization looks like in the field of global surgery. Tomorrow, we will start with a panel themed around international perspectives in global health, where we will feature global health leaders working on the ground from all corners of the world. We will also hear a keynote from Dr. Jolade Kalinowski, who will present on her research on the relationship between stress and cardiovascular disease disparities in Black women here in the United States, as well as just the social determinants of health. On Sunday, we will host a think tank networking and reflection session, where glohsoc members will present some information regarding decolonization of global health, and members will have the opportunity to talk to one another and chart their own path into global health changemaking. Over the course of this weekend, we hope to immerse ourselves and all of you in the vast field of global health. We will discuss not only health inequities in the United States and across the globe, but will also help you understand the common underlying socioeconomic, geopolitical, and cultural determinants that contribute to them. You will have the opportunity to look at the nuances of healthcare, acknowledge the hurdles that exist, and critically think of how we can craft creative, culturally competent solutions to those problems. We encourage you to keep an open mind and an eager heart and learn not just from our presenters, but from one another. We encourage you to attend the networking session, especially during our Sunday session, and start thinking about how you can take what you learned this weekend and apply it to your everyday life and possible future career paths. We hope you walk away from this weekend knowing that you have the ability to have a huge impact on the field of global health, and that every one of you has a critical role in breaking down barriers and colonial legacies and building a healthier, more connected world. By choosing to be here today, you have already taken your first step towards working for a more equitable world, one where every individual has access to quality and affordable healthcare, regardless of their background, beliefs, or circumstances. UConn Global Health Spaces on Campus proudly presents our 4th annual Global Health Symposium, Decolonizing Global Health. So on that note, I would like to welcome and introduce our keynote speaker for our symposium opening today. Dr. Nichole Starr is a general surgery resident at the University of California, San Francisco, a senior fellow at Lifebox Foundation, and an NIH Fogarty Scholar. Her areas of interest are in academic global surgery, surgical quality improvement in infection prevention, and strengthening trauma care systems in resource-limited environments, as well as trauma-induced coagulopathy and platelet function in injured patients. Dr. Starr served in the Peace Corps in Ethiopia from 2007 to 2009 and has worked in Ethiopia, Brazil, and Liberia on health service research and improving care for HIV/AIDS, tuberculosis, and surgical quality improvement. Her talk today is titled Anti-Neocolonialism in Global Surgery, a call for the next generation to change the paradigm. Without further ado, please give a warm welcome and a round of virtual applause to Dr. Nichole Starr.
Thank you so much, Amisha. Let me share my screen with you all. Okay. Thank you so much for the warm introduction, and thanks to the University of Connecticut and for the brilliant group of student organizers of this symposium for giving me the opportunity to speak today. I'm really humbled and excited to share some thoughts with you all on how we can foster anti-neocolonialism in the field of global surgery, and how you all, as the next generation, can help to change the paradigm. So before I begin, I have several disclosures. Firstly, I am a white American woman, and this means that by definition, I am from the background of colonizers, not of the colonized. This also means that I will have an incomplete understanding of many of the issues that are discussed in this talk. And at all points in the session, my aim is not to speak for my colleagues, as that would be quite antithetical to the title I've proposed, but rather to share some of my own struggles with the work to be anti-neocolonialist, as well as a lot of the published work of others. Most of my work experience abroad has been in Ethiopia, a nation that was never colonized. Therefore, there might be differences in the types of interactions, relationships, the frustrations and solutions between visitors and Ethiopian nationals as compared to other nations which are truly post-colonial. Because of my race and nationality, I've never experienced racism or colonization, and I often still feel conflicted about my own work. I do not purport to have all the answers in this talk, but I hope some of my suggestions will resonate with you. Finally, I love Ethiopia, which is like a second home to me, and I love Lifebox, the organization that I've been proud to work with for the past 3 years. So I'll start today by giving a brief historical background of global health and global surgery, then share some of my ongoing journey to become an anti-neocolonialist with 6 short stories. I'll tell you about how a can of vegetable oil, an inauguration, an eavesdropped conversation, an ultrasound machine, some trash cans, and a protest in San Francisco all taught me different lessons in becoming anti-neocolonialist. And I'll end with some suggested steps to change our mindset and practices and a vision for the new paradigm. One of my favorite quotes in this space is by Lila Watson, who was an Indigenous Australian, an artist and an activist protesting for Indigenous people's rights and the anti apartheid movement. At the 1985 UN Decade for Women's Conference, she said, "If you have come here to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together." This expression of deep partnership and solidarity is really the ethos of this talk. So, to start off, I want to share a bit of introduction to the people with whom my liberation is bound up with. I could have 10 slides like this, but pictured here are just some of my cherished colleagues and friends, from our Lifebox office in Ethiopia to my colleagues at the Ministry of Health, our McCaskey Fellows, the trauma teams at Alert and Abate, my Peace Corps host family, and my Peace Corps counterpart and his family. The kindness I have experienced from each of them is profound, and I am very grateful. In a continuum, many of these incredible people are friends and colleagues and mentors, are some of my teachers. I stand on their shoulders, these mentors who were generous enough to show me the ropes, say the hard things, and help me grow personally and professionally over the years. So now let's start near the beginning of coloniality and global health. In 1899, Rudyard Kipling wrote the poem, The White Man's Burden. Kipling wrote this poem at the point that the United States first became an imperial power, which was invading the Philippines. Hoping to convince the US to engage in a more humanitarian form of imperialism, with his belief that non Western and primitive peoples were waiting to be developed and improved, he sent this poem to Theodore Roosevelt and published it widely in news outlets. One of the stanzas most related to health reads, "Take up the white man's burden, the savage wars of peace. Fill full the mouth of famine, and bid the sickness cease. And when your goal is nearest, the end for others sought, watch sloth and heathen folly bring all your hopes to naught." His racist view of white imperialism and white colonialism was that of a selfless moral duty to bring modern and civilized society to non white societies. While it's now very disturbing to read such a poem, it's hard to argue that notions of a white or Western savior bringing life saving interventions to destitute, remote locations of the globe have been completely eradicated from our worldview. If you watch late night fundraising commercials for many charity organizations, they evoke the same sort of images. As an answer to the poem, an African American pastor named H.T. Johnson wrote a reply entitled The Black Man's Burden in the same year. It reads, "Pile on the black man's burden. 'Tis nearest at your door. Why heed long bleeding Cuba or dark Hawaii's shore? Hail ye your fearless armies, which menace feeble folks, who fight with clubs and arrows and brook your rifles' smoke. Pile on the black man's burden, his wail with laughter drown. You've sealed the red man's problem and will take up with the brown. In vain ye seek to end it with bullets, blood, or death. Better by far defend it with honor's holy breath." More than 100 years ago, Johnson wanted to make the point that the mistreatment of brown people in the Philippines was an extension of the mistreatment of Black Americans at home. During this time period was the birth of colonial medicine. Kim and colleagues in this paper explore the historical development of global health and its impact on our current practices today. The colonial heyday of many Western nations was in the latter half of the 19th century, with the expansion of colonial rule and the wider settlement of colonized lands. Infectious diseases began to afflict the foreign colonizers. Some of the earliest global health initiatives were to understand and treat diseases such as tuberculosis, malaria, cholera, and yellow fever. These investments were viewed as important to protect the health and economic interests of the colonizers, but little mind was paid to the colonized, except in the cases where treatments would increase worker productivity. At the end of the Second World War, the global health landscape underwent a major shift, with nations polarized between the capitalist West and the communist Soviet bloc. This led to the ideological differences in the provision of and payment for healthcare, with Soviet affiliated countries developing more universal healthcare systems and Western or US affiliated countries relying more on free market delivery of healthcare. In the 80s, we saw the collapse of the Soviet Union and the purported triumph of Western liberal democracy. Free markets, deregulation, and privatization were on the agenda. Structural adjustment programs were started at the IMF and World Bank, which provided loans to countries that promoted such practices. These loans proved challenging to repay, which led to austerity measures that economically crippled some African nations, and cuts in public services as part of the loan conditions led to growing health inequities. Surgery first appeared on the global health scene in 1980, when the former director of the WHO, Dr. Mahler, stated that surgery has an important role to play in primary health care. People in need must access skilled surgical care at first-line referral hospitals. He added that lack of surgical access was the most serious manifestation of inequity in healthcare. Previously, surgery was felt to be a luxury item in the global health world, expensive, optional, and Mahler's mention of surgery as important to primary healthcare started to change that. Several other milestones occurred in 2015. The World Health Assembly passed a resolution on strengthening emergency and essential surgical and anesthesia care as a component of universal health coverage. The disease control priorities included a volume on essential surgery for the first time, which recognized surgery as a key area of healthcare in low resource settings. And the Lancet Commission on Global Surgery was also published, which quantified some of the access, safety, and affordability issues for surgical care across the globe. That commission also set targets for 2030 that provided a framework for the field of global surgery to emerge in its own right. For more reading, if you're interested, I've included a few of my favorite books here. So much like reading Howard Zinn's A People's History of the United States in high school flipped American history on its head for me, these books take a very ground up view of global health and offer very different perspectives than some of the more classic reading that I had done during my public health education. One of these books is by Kwame Nkrumah, the first president of Ghana following its liberation. He coined the term neocolonialism and describes it here. In place of colonialism as the main instrument of imperialism, we have today neocolonialism, which, like colonialism, is an attempt to export the social conflicts of the capitalist countries. The result of neocolonialism is that foreign capital is used for the exploitation rather than the development of less developed parts of the world. Investment under neocolonialism increases rather than decreases the gap between the rich and the poor countries of the world. The struggle against neocolonialism is not aimed at excluding the capital of the developed world from operating in less developed countries. It is aimed at preventing the financial power of the developed countries being used in such a way as to impoverish the less developed. Richard Horton, the editor of The Lancet, wrote a piece in 2013 where he posed the question, is global health neocolonialist? He seems to believe so, and writes that global health is a product of nations whose histories are characterized by the struggle for power, wealth, and influence. Is 21st century global health just a polite way to decorate these repackaged colonial ambitions? He characterizes some global health providers as the new missionaries, guilty of naivete, self-righteousness, and grandiosity. And much of the terminology in global health is laden with condescension. Post-colonial low-income nations have been grouped and labeled as the third world, underdeveloped, developing, and low resource. Each of these terms employs some victim blaming and labels the group as needing assistance with development or with resources. These conditions are viewed as the natural state and something we need aid to fix. But the history of this natural state is bound up in global history. These terms ignore the fact that development was interrupted by colonization, and subsequent to that, the hegemony and economic imperialism still dominates development agendas. Many of these countries are in fact not low resource at all, but rather their resources have been pilfered by the very groups that now offer development assistance and donations. To this day, the rubber plantations in Liberia, Mining in the Eastern Congo is owned and operated by former colonizers. Before we get to story time, I'll share one last quote to set the stage. If you live on a mountain, abundant with sustenance and resources, but the very soil of the mountain is the bones of souls who were oppressed and gave their lives to build the mountain, and the mountain is still being held up by the living descendants of those souls, descendants laboring under the oppressive weight of the mountain, shouldering and grieving the mountainous weight of their ancestors, you could say to yourself that your life is wonderful and the mountain is wonderful, and you have every right and entitlement to the mountain because of a myth of meritocracy that says those who live atop the mountain earn their way up by their own bootstraps and superiority. Or you could say, damn, my place atop this mountain and the mountain itself are both built on the backs and bones of suffering souls. Maybe they too should benefit from what the mountain offers. Or better yet, maybe we should build a whole new mountain, one whose soil is not composed of tortured bones. So, with all that being said, global health bears many of the traits of neocolonialism. And as a field within that, global surgery too. And we can do better. We must do better. I believe we have a unique opportunity in such a young academic field to really galvanize some of the principles of anti-neocolonialism and to build a field of academic global surgery that includes ethics and equity at the forefront. But to do that, we need the drive, energy, and creativity of the new generation. And that, my friends, is you. I want to share with you 6 short stories that illustrate some of the problems of coloniality in global health and global surgery, and the lessons we might take from them in building a new paradigm. I'll start with a can of vegetable oil. It was 2007, and I had just settled into my Peace Corps site in Dese in northern Ethiopia. One of my first engagements was with the town organization for people living with HIV and AIDS. Their office was on a hill across from the main market, and I would go hang out there several days a week, getting to know the organization. The group would do regular food aid distribution to their members, all of which seemed to be labeled with USAID. On the first day of distribution, I watched mostly women come collect their portions, a giant can of vegetable oil, some rice, and some cornmeal. One by one, I saw them collect the food, march across the street and into the market, and plop down on the ground and start selling their rations. It struck me as so odd. I asked one of the society leaders what was going on. He explained to me, no one likes cooking with that oil. It tastes funny, but they can sell it cheap to get a bit of the cooking oil they prefer. It was the same story with the rice and the cornmeal. There's not a lot of use for these grains in the Ethiopian diet, but they could be sold cheaply and at least generate some cash for the women to buy what they really wanted. There were other uses for the cans of vegetable oil, to be sure. This photo is from a home constructed from the tin cans, and it comes from a photojournalist. But seeing shops and homes constructed, at least partially of these cans, was common back then. The organization and presumably USAID knew this was going on, but it still struck me as so weird I couldn't shake it. Why was this food being shipped across the ocean from the United States, food that people didn't want, just to be sold and generate cash for other purposes? Was this really the model that the development world was using? A quick internet search made it all clear. This model was helping us. The hundreds of millions of dollars of food aid donated by the US each year must be shipped on US flagged vessels, and American farmers are happy to receive subsidies for their crops to be bought up by the government and donated abroad. In 2007, about 2/3 of the budget for food aid went to non-food costs, including transportation. An accepted strategy of utilizing donations was to monetize them, which our organization in Dese was clearly doing. This involves selling the food at usually below production cost to generate cash. And this article from The Guardian references an iron triangle of agricultural business, shipping companies, and NGOs that benefit from this scheme and block reforms. There have been some changes made to the program since my time in the Peace Corps. It's gotten better with more locally and regionally sourced food aid, but still last year, 41% of food assistance was direct food donations from the US. This self-serving donation mechanism sets up a really backward model. Instead of understanding needs on the ground and directing efforts to meet those, this model prioritizes the economic interests of the donor, or we could call them the colonizer, delivering suboptimal, wasteful, inappropriate resources to the recipient. It sets up a facade of altruism that masks a truly colonial for-profit enterprise. This story illustrates the need to examine the economics of our global health practices and the egotism, whether at an individual or national level, that drives such programs. An anti-neocolonial behavior would be to eradicate the self-serving donation culture and to remove profiteering from the global health machine. The second story I'll tell you is about inauguration. It was later in my Peace Corps service, and I had struck up a friendship with a physician in my community who was from a rural area about 20 minutes outside of town. A foreign embassy had made a huge investment for a community training center in this district, and we made frequent visits during its construction. The inaugural ceremony was a huge event. The community elders rode in on horseback with special saddles and bridles. The community center rooms were buzzing with activity. People were taking tours of the clinic and the sewing room and the IT center. And this went on for several hours. The pictures here show the community members who had gathered for the event, and then all these speeches being made over a bullhorn. We had cake, we were dancing. The community gifted us with these traditional handmade dresses for me too, although I did absolutely nothing to contribute to the effort other than to show up. And the group of donors from the Capitol packed up around 3 o'clock to begin the long drive back. I imagine they were feeling really proud of themselves for the day and the project at large. And this is what I would call a white savior, or at least a rich savior moment, feeling that they had done something great and generous and gracious, and their recipients were grateful. However, the community center never really opened. This staffing was spotty, and the lack of consumable supplies caused the clinic to remain mostly closed. It sat empty for the rest of my time there. Sometimes I had meetings, but not much else. And the thing is, the community never asked for this center. The families in this district were mostly subsistence farmers. If asked, they would have wanted loans to buy cows for more efficient plowing of the fields, or a banking system to keep their savings secure. This was an example of global health arrogance, as my friend Professor Abebe Bekele would call it. Welling and his colleagues enumerate the 7 sins of humanitarianism, of which the group in the previous story committed more than one. I would argue they committed sins 4 through 6, failing to have a plan for following up, allowing distracting goals, such as constructing a physical edifice to trump service, and going where they were not wanted, at least not in the capacity in which they came. We must all be on guard for committing these sins of humanitarian medicine when we work abroad. As they say, the road to hell is paved with good intentions. Focus is also shifting in the global surgery world. Once the mainstay of global surgery work, surgeons are now rethinking short-term missions and the negative impacts they might have on local populations. A paper by Schreiner and colleagues explores some of the pitfalls of surgical missions. While the aim of campaigns is usually to treat the unmet surgical needs of a community, they can result in a lack of confidence in local surgical providers. They're usually focused narrowly on one procedure and don't always allow for postoperative patient follow-up. These campaigns often actually interrupt the routine provision of surgical care by local providers, and sometimes either surprise local providers or exclude them from participating. Then there are concerns about the visiting surgeon. They may actually be less qualified to function effectively within a system that's very different from home. Ethical issues around voluntourism are also raised, with a classic example being the selfie with a destitute patient, kind of fetishizing their suffering for moral superiority with their peers while doing little to change the actual circumstances of that patient's life. As students, it may feel overwhelming to enter a system that's teeming with so many ethical challenges and colonial overtones. Jane Philpott has a nice paper that calls upon students to examine their own motivations for working in the global health space and work on suppressing some motivations, such as the glamour of becoming an MSF doctor, and cultivating motivations focused on unity, equity, and justice, like understanding social determinants of health and advocating for all patients. Everyone will have both selfish and altruistic motivations for participating in global health and global surgery work. But by examining these and choosing which side we want to cultivate in ourselves, we can work towards setting the stage for more respectful and useful partnerships. Thinking back to the community center inauguration, if the donors had aligned their motivations and mission with the recipient community, I doubt the same choices would have been made. To move toward an anti-neocolonial paradigm, I would encourage all of us to focus as much as possible on long-term commitments to work that's identified locally as a priority and to work within a system rather than in parallel. Finally, we must suppress any desires to glamorize or commoditize human suffering for our own moral superiority, whether it be for an Instagram post or otherwise. The third story I'll share is about a conversation overheard in an operating room in Ethiopia. I had just arrived as a research resident a few years ago and was getting to know the hospitals that were working with us on a quality improvement program to reduce surgical site infections. I was observing the use of the surgical safety checklist in the OR. When the case ended, the surgeon didn't do the last part of the checklist. Seeing me in the corner, and I think knowing I was observing, one of the nurses ran to grab the surgeon, who came back to the OR and pretty loudly ran through the sign out. Afterward, he called his team over to the door of the OR. He spoke in Amharic, which after my time in the Peace Corps I could understand, but there's no way anyone would have assumed that. I heard him telling his team that this was an outside, imposed project and was out of touch with the work in their ORs. He told the team to go along with it, but essentially that the lessons didn't apply here. Of course, I was shocked and mortified. I couldn't believe that one of our lead surgeons at the hospital thought our program was irrelevant to their priorities. And I really started to question the entire purpose of what we were doing. But after taking a bit of time to reflect, I realized that that was a really important moment that not many people get to experience in global health. I was hearing exactly what he thought about our work and my presence there without any filter or the cultural niceties that usually color such conversations. And the message for me was we were out of sync. Something that can be difficult for colonizers to internalize is that our Northern voices dominate discussions in global health. Looking at this on a macro level, the majority of leaders in the Lancet Commission, the Consortium of Universities of Global Health, the World Health Summit are all based in the global North. A study by Global Health 50/50 looked at the income distribution of global health leaders as well. So while representing 17% of the global population, 83% of the global health leaders are from high income countries, and just 50% of them are from the UK and US alone. 92% of degrees obtained are from high income countries, and 8% of those are from Harvard, which is the same as all degrees obtained in low and middle income countries combined. So when one group dominates the leadership and education space, how can voices from both be heard equally? The editor of BMJ Global Health, C.A. Abimbola, reflects on how this power dynamic impacts authorship in the academic global health as well. The foreign gaze in global health refers to the fact that the majority of authors of global health papers are writing about foreign contexts to them with a foreign pose and are consumed by other foreign readers. Whereas prior to the last 50 years or so, most meaningful research and impactful health interventions were driven by local research for the local community. Dr. Abimbola reflects that there's a problem of gaze at the heart of global health. Imagine replacing the word white with the word foreign in the quote by Toni Morrison, and it may become more clear. I have spent my entire writing life trying to make sure that the foreign gaze was not the dominant one in any of my books. The people who helped me most arrive at that kind of language were African writers, those writers who could assume the centrality of their race because they were African. And they didn't explain anything to foreign people. Things Fall Apart was more important to me than anything, only because there was a language, there was a posture. I didn't have to be consumed by or concerned by the foreign gaze. He reflects that many of the salient conversations about health policy and healthcare delivery in LMICs are often not in peer-reviewed journals, but in WhatsApp and Telegram group chats, in the local news, and finding a way to cross paths, at least occasionally, between the local and the foreign gazes on global health issues is an important step towards a more meaningful dialogue. This blog post by Dr. Madhupai further reflects on the Northern dominance in the global health space. He starts the article reminiscing about his medical training in India, where swaths of American and European students would come visit his medical school. They would stay for a few weeks working on a project and go home to publish their research in an international journal. Despite having many more insights than the visitors into the local pathologies and presentations and interplay with cultural realities, Dr. Pai did not get to publish much. The research agenda was driven by big funders and global health agencies, and much of the power in setting the agenda, publishing, and editing is based in the global North. The field of academic global surgery is exploring how to foster more ethical and equitable partnerships between foreign and local partners. A recent paper by many of the leaders in this field sets out ethical principles for US institution engagement in global surgery partnerships. There's a focus on local priority setting, equitably sharing resources, and how to ethically and transparently engage in clinical care and research. Taking the foreign gaze into account, publishing in international journals should not be the only way to engage in discourse about setting priorities in global surgery. Live discussions and debate can contribute as well. A number of partners from Lifebox and our colleagues from a wide representation of LMICs has started holding transformational dialogues on topics in decolonizing global surgery. So what have we learned from this eavesdropped conversation? Inclusion and equity in global surgery partnerships is essential. Trust and relationships must be built and should take priority over setting programmatic goals. Without these, open and honest dialogue cannot be had. Local partners must be included from the ground up in setting the research agenda in global surgery and should receive their fair share of academic benefits for the work. The next story I'd like to tell you is about an ultrasound machine. I had been working at Alert Trauma Center, supporting the establishment of a trauma registry for about a year and a half. I knew the staff well, and while I didn't provide clinical care at the hospital, I was often in and around the emergency room, the wards, the ICU, following up on patient documentation for the registry. One afternoon in the ICU, one of the physicians approached me. They had a patient who had been transferred from an outside hospital after a fall from some height. He had a head injury and was persistently hypotensive. The CT scanner was broken, as it had been for some time, and the team wanted to perform a FAST exam, which is essentially an ultrasound of the abdomen and chest to look for clear signs of bleeding, among other things. But no one at the hospital who was there at the time knew how to do it, and they wanted to know if I could help. This is an exam I perform routinely at my hospitals in the United States, and I feel very comfortable doing independently. I teach junior residents and students how to do it as well. But here, the question sort of gave me pause. I was outside of my element without my usual strategies and backup. If it was a difficult exam, there was no senior to call. There was no radiologist to help me interpret the images if I was unsure. And what if the FAST was positive? I would want the patient to go to the operating room. Did we have OR capacity? Was there a surgeon available? And most importantly, what if I were wrong? For a simple question, it seemed like a complicated decision. Ultimately, I decided my comfort with the technique and my understanding of the hospital system, along with the importance for the patient, were sufficient to go ahead. I walked the physician through performing the FAST exam, much like I would in the US. It was clearly negative, and we were reassured he was not bleeding. But decision making around clinical care in foreign environments is rife with much more difficult questions than this. When considering providing clinical surgical care in low income environments, high income trainees and surgeons may not be as prepared as they think. Looking at the experience of American surgical residents, almost all of our experience is in essential and advanced general surgery. Whereas in an organization such as MSF, the case mix includes obstetrics, orthopedics, and urology procedures, many of which American general surgeons would not be trained to perform. Taking this into account, the Association of Surgeons in Training published recommendations for trainees wishing to engage in global surgery work, including provision of skills training courses and appropriate supervision, but also with a focus on mutually beneficial partnerships and to ensure they're not displacing local trainees. If we revisit the importance of local priority setting, sometimes the provision of direct clinical care is not the best way to engage in global surgery work. In a survey of African pediatric surgeons asking how they would prefer international partners to help, providing direct clinical care was the lowest ranked area, whereas training, teaching, and helping to fundraise were all viewed as more important. I've borrowed this slide as well from one of my mentors, Dr. Osgadiz, who shared some salient do's and don'ts for visitors who do choose to participate in clinical care from a colleague, Don Meyer. These are simple and helpful for any student or trainee to review. Do remember you are a guest. Track cases. Try to understand why things are the way they are. Have a sense of humor. Go back to the same place. Don't complain. Try to make sweeping reforms or blame hosts. This is at least a good place for visitors to start. But what are some of the pitfalls of international rotations in global surgery? Shiner and colleagues also explore this, questioning if international rotations are being used to close gaps in US-based training, as trainees can see a huge volume of advanced surgical pathologies in LMIC environments. But ultimately, what is the benefit to the LMIC trainee, to the site, and to the patients? LMIC trainees may be displaced from their own training by high income visiting trainees and are not afforded reciprocal training opportunities in high income countries. Most visiting high income trainees do not return to the same location after their international elective either. So it's hard to argue that patients in that community would benefit in the long term from providing that trainee with a clinical experience on their patient population. Taking these more broadly, how can we decolonize these traditional experiences in global health and global surgery? A very recent paper by Dean Garber and colleagues tackles this, calling for us to diversify global health education in high income countries by teaching the history of colonial medicine and ethics, by de emphasizing short term unidirectional engagements, and providing more pre visit training to decrease the burden on hosts. They also call for the recruitment of faculty that will promote more long term equitable collaborations. So, from thinking about the use of an ultrasound machine in Ethiopia, we as high income clinicians are cautioned against engaging in predatory practice environments that provide training opportunities that only benefit the visiting trainee. Rather, we need to look for clinical experiences that are requested by local providers that clearly benefit LMIC trainees and patients, in addition to the obvious benefits to high income trainees. Next, I want to pose a hypothetical question to the audience. How many trash cans should be full after a routine operation? We see side by side here two operating rooms. The one on the left is in Liberia. Here, equipment like patient drapes, gowns, plastic tubing, cautery pieces, endotracheal tubes will all be reprocessed and reused. This is unconventional in the United States, where most medical equipment is single use. The OR on the right is at my hospital in San Francisco. After finishing a routine operation, you can see the trash can bulging with the consumable waste generated by a 1 hour case. Which one is correct? I want to use this example to question a notion that we, the colonizers, often hold, that we are right. Oftentimes, the approach to global health and global surgery presupposes that the practices in the high income world are better than those in low income settings. Is this always true? What can we learn and improve from the lessons of a more austere environment? The scarcity of many LMIC environments may promote innovative and efficient practices that could be more widely applied. This paper by Gautier attempts to deconstruct the traditional notion of global health research partnerships for just this reason. Without allowing space for local partners to generate the research questions that will be funded and investigated, how can we identify the key learnings and new evidence to be generated from that environment? By establishing truly bilateral partnerships with strong mentorship from both high income and LMIC mentors, we may be able to start asking the right questions and build more productive and reciprocal relationships. The scarcity in some environments may provide learning opportunities that excess does not, and bidirectional learning can maximize the benefits to all parties. We should look for lessons in efficiency and innovation from the LMIC context that can be applicable globally. I want to wrap up with a final story from San Francisco. This summer, when the Black Lives Matter protests were happening across the US and the world, I took to the streets with many others in San Francisco. This was an emotionally devastating time for many of us, once again reckoning with some of the ugliest aspects of our culture and society. In reading more, educating myself, and thinking deeply about some of the learning I and others had to do to become anti racist rather than just not a racist, many of these themes resonated with what I would aspire to for anti neocolonial work as well. Ibram Kendi outlined several steps that are helpful on the journey to becoming anti racist. One must understand the definition of a racist, stop asserting, I'm not racist, identify the race based inequities and disparities, confront one's own racist ideas, understand the intersectionality of anti racism, and finally, champion anti racist ideas and policies. Angela Davis said, in a racist society, it is not enough to be non racist. We must be anti racist. Of course, anti neocolonialism is a different topic, And the importance of the anti-racism movement should not be conflated or diluted in any way. That important work must continue with the same energy, and in so many ways, the work has just begun. But there may be learnings we can take from the anti-racism movement that can inform efforts to become anti-neocolonial. This NPR article by Abrar Karan explores his own experience with global health and some of the disturbing colonial approaches of global health programs, including much of what we have discussed today: short-term missions, incomplete follow-up, unsustainable work and broken promises, benefiting from global health work on your CV. He calls for us in the post-colonial world to dismantle our own power as former colonizers, to disabuse ourselves of the notion that the global North is always helping the global South, and to understand the overlap between global and local disparities in health equity. He states, if you're from a high-income country working in a low-income setting, and you don't think and rethink about this topic often, there's a good chance you're contributing to the problem. We have to start taking an active role in the process of decolonization. It is no longer enough to be not a colonial thinker. We must recognize we are born and bred into a system that perpetuates these inequities. Just as we have to retool our thinking and actions to be anti-racist, we must also become anti-neocolonialist in a similar fashion. This involves examining and breaking down the structures we live and work in. It may involve a challenging examination of our own motivations and past actions, but we are up to the task. Some of this work may create feelings of guilt. This is normal. Richard Horton wrote another editorial in The Lancet about transcending this guilt, stating, any Western medical institution more than a century old, which claims to stand for peace and justice, has to confront a painful truth, that its success was built on the savage legacy of colonialism. He calls for a new generation, one that is more angry and activist, and that is prepared to reimagine our collective existence. And I think that is us. As a final note, I would propose some steps to cultivate an anti-neocolonial mentality. We must continue to read, educate ourselves, ask questions, and when the answers come, to listen. Interrogate your own motivations and cultivate those that are driven by equity and justice. Examine the benefit and cost of your participation in any global surgery or global health work. Try to maximize benefit and minimize cost to your colleagues. Critique your skill sets honestly. Clarify the us and them priorities in global health work and deprioritize the us. Ask for help early and often from your mentors, colleagues, and friends, and solicit criticism and then take it with an open mind. I hope in the past hour, I've presented a compelling account on why and how we need to become anti-neocolonialist in global surgery. Starting from the colonial and racist white man's burden, or imperialism disguised as false humanitarianism, we have in many ways moved on to the notion of the Black man's burden, a neocolonial attitude that embraces charity and victim blaming as a way to preserve the moral superiority of former colonizers. But we are now moving toward a paradigm of shared liberation. The deep thinking and action around becoming anti-neocolonialist has taken hold, and this future will be led and realized by all of you. I'm really excited to learn from the other speakers and panelists at the conference, and thank you again to the Symposium for allowing me to speak with you today. I want to recognize again all of my teachers and mentors and my colleagues and friends who have and continue to teach me every day. Thank you very much, and I'm looking forward to our discussion.
Okay, great. Thank you so much, Dr. Starr. That was a really informative talk. Very, very, very informative. So I would like to move on to our question and answer session for this evening. And so for the way that this will work is at the bottom of your screens, you all should see a Q&A feature, which should be right next to the raise hand button at the bottom of the screen. And for all the attendees, you can type in your questions into there and we'll be able to share them with Dr. Starr and In that way, we'll be able to continue our Q&A in a organized fashion. In addition, we will also be sharing some links in the chat, one to enter our ongoing raffle this weekend, and the other for those of you who are attending for class credit or for extra credit. You can fill out that form so that we can share with professors that have requested it. Please do fill these forms out before the end of this session. And now I would like to introduce our moderator for the evening, Dr. Hareem Park. Dr. Hareem Park is a pediatric hospitalist at Connecticut Children's, as well as an assistant professor of pediatrics at the University of Connecticut School of Medicine. Dr. Park also has extensive experience in the global health space, as she has volunteered with an HIV/AIDS clinic in the Dominican Republic, Central America, participated in the Amazon Community Health Program in Ecuador, South America, and cared for patients in inpatient and critical care settings in Botswana and Saipan. Recently, she worked with Doctors Without Borders as a pediatric specialist, training local care providers in South Sudan. Currently, she works with the Center of Global Health at Connecticut Children's, focusing on bidirectional educational opportunities with pediatric residents and global partners. So yes, I'd like to welcome Dr. Park, and Matan, if you wanted to spotlight both Dr. Starr and Dr. Park. Okay, great. Yeah, so I think we can get started. Dr. Park, if you also wanted to introduce yourself, that's totally good as well.
Yes, hello. That was so excellent. I really enjoyed listening to that. Thank you, Dr. Starr, for sharing such an expansive look to all of us in regards to the history for colonialism and now neocolonialism within global health and some of the strategies to promote anti-neocolonialism. I think it was a great start to our weekend of global health. So thank you for that. So I suppose while questions are being generated, I can start off with the question, if that works. So as M.P.H had stated, my kind of more prominent and recent experience lies in work that I did in South Sudan as a pediatrician working for Doctors Without Borders and Médecins Sans Frontières. And it's a difficult task to be anti-neocolonialist, I think, because in essence, we're popping ourselves into their community or into a community that is not our own. And the whole premise of that, I think, is a bit colonialist. And so it's really important, as you've stated, to kind of think through what are our motives, how are we helping them, and what help do they need to kind of start the work from a good place. And so some of the kind of difficulties that I think we encounter with this work is creating that trustful place and making known that we're trying to develop a bidirectional relationship. So I'd be curious to hear kind of what are some of your strategies that you've used to kind of collaborate with, develop partnerships with some of the local members of the communities that you're working with to be able to establish kind of hopefully a long-standing, fruitful relationship.
Thank you, Dr. Park, for that question, and thank you for all the work that you do. I can only imagine how challenging it is to work in such devastated and conflict situations. And I know that there's probably a lot of superimposed challenges in that environment that I have never encountered in Ethiopia. So thank you for that. I mean, I think there doesn't have to be one way of effectively engaging in global health and global surgery. And I certainly don't want to give the impression that I don't think there's a role for humanitarian and for sort of emergency relief missions. In my view, the provision of clinical care, especially emergency and life-saving clinical care in conflict situations where healthcare systems may have been devastated by war, famine, et cetera, is very different than sort of going in with the mindset of engaging in a long-term academic partnership. But that being said, I think there's probably a lot of strategies that might overlap and might make that experience more successful or more inclusive of local providers when you have the opportunity. And I think in general, some of the strategies that have worked best for fostering relationships for me are time spent, culture understood, language learned. Really, the more you can entrench yourself into understanding what that environment looks like, understanding, asking questions about the history of a particular place, the religion, learning some of the language, will just, for me, has always given me just a little more insight into how and why providers and patients present as they do, and the choices they make, and gives me a little bit more perspective on how I might successfully engage. But I guess I can also reflect on what a jarring experience it was for me to go work in Liberia in the past couple of years, because at this point I've spent almost 15 years in and out of Ethiopia. So when I say it's like a second home, it really does feel like a second home. Like I feel like the transition is very fluid, and I don't come up against those cultural obstacles the way that probably a lot of people do when they're going to a new place. And so I'd almost forgotten that that could be such a barrier until going with some of my colleagues to Liberia to deliver a workshop and do some scoping for future programs there. And then it all came crashing back in, how little I understood about the culture, how my assumptions that things might be the same as I had learned they would be in Ethiopia were completely wrong. And I had to go back to square one and sort of ask the questions again, understand, things as simple as like, how do we organize the day? When do we take our tea breaks? Like, how do people like to take their lunch break, et cetera? Like all that stuff was just all wrong. And so no matter what context we find ourselves in, like, I think you constantly have to go and reevaluate that and ask the same questions over and over again, and try to entrench in the local culture once again to sort of be as effective as possible.
Yeah, I think that's great. A lot of this, comes from listening and observing and not shouting and making your presence known. I think you can learn a lot just by kind of observing at the beginning. All right, we have some questions coming in. So this is a question regarding kind of how you used your knowledge and your experience during your time in the Peace Corps to change the strategies that you use to assist the communities with whom you now work with.
Great question. And I think it's very instrumental to my work every day. I recognize that the fact that I speak Amharic is incredibly important, not only to being understood and to being effective communicating, but also in generating that feeling of trust and familiarity. And it's a huge relationship builder. As much as possible, for young people who are just kind of starting this journey, I would really encourage you to take a deep and narrow approach rather than sort of a scattershot wide approach, because I just think that the experience will be so much richer for both parties if there's another place in this world that you can really start to understand and to build sort of that collaboration with. And it just gets better and better over time, rather than, as I mentioned in Liberia, constantly feeling like you're needing to reinvent the wheel or going to bang your head against a wall again about something else.
Yeah, I'm so impressed that you're able to learn a whole new language in the past and be proficient in it. That's incredible.
There wasn't a whole lot to do in some of that Peace Corps time. And not a whole lot of people who spoke English. So it was kind of like a sink or swim phenomenon.
Yeah. Yeah, sometimes that's how you learn the language best. It's just by being forced to speak it and being immersed in it. So, well, what a skill. Another question is in regards to, if you feel that there are any specific day-to-day practices at the individual level that you've either modified, eliminated, added in order to be anti-neocolonialist in the work that you do.
I think a huge one for me, and it's something that, to be honest, I'm still working on, is shutting up. I think our culture as Americans is very loud and can be very forceful. And particularly coming from the field of medicine where everyone has worked so hard and, we're obviously ambitious, high achieving people, it's hard to resist the impulse to speak up and to assert your position about something. But what we all have to realize, and what I hope I partially communicated in the talk, is we're often not right. And even if something might be right here in San Francisco, it's probably not right in Addis. And so what I need to do, and what we all need to do, is resist that impulse, hopefully at least 50% of the time, and let others do the talking, and try to reflect that back and support the ideas of your colleagues, because they know what they're doing a lot more than we do.
Yeah, absolutely. I think something that I did early on in my work abroad would be to be quite judgmental in retrospect, and it's just not the place to come from, because again, these people, they're welcoming you. This is not your home, it's theirs. And I think it's just an easy thing to fall into in terms of feeling superior, feeling like the savior, as you mentioned in your talk. And so it's a good, always good to remember to be humble. Another question is, are there any global health organizations that you know of or you regard highly in terms of being anti-colonialist?
Well, as I mentioned in my disclosures, I love Lifebox. But I think a lot of global health organizations have taken up the mantle of this recently. And I mean, I really do think the understanding that this is a field we need to radically change is coming to the forefront. It's not just a fringe idea anymore. But I congratulate Lifebox on the priority they always put on having the voices of low-income country partners heard and represented, the voices of women represented. It's something that the organization takes really seriously, and they've prioritized having these transformational dialogues in Decolonizing Global Surgery, which is really important for us to start kind of like changing the paradigm of how we even communicate about these things. Mm-hmm. A lot of our colleagues aren't going to go write an editorial in the Lancet. That's still, even though it might be hearing something important, it's still hearing a colonial voice. And so we have to build spaces and build opportunities for voices of providers who actually work in those contexts to be heard and to be recognized. And maybe that's in webinars, and maybe that's in Telegram chats, and maybe it's on Twitter. But we have to start recognizing those as legitimate spaces for discourse and giving those credit and stuff.
Can you tell us a little bit more about Lifebox? It's not an organization that I'm particularly familiar with, and I think it would be nice for our audience to hear.
Absolutely. So we're a fairly small nonprofit organization that was founded in 2011, initially with the key program being providing pulse oximetry, high quality, affordable pulse oximetry to low resource operating rooms. Our founders were mostly the group that worked on the creation of the surgical safety checklist. And so our focus has always been around promoting safety in anesthesia and surgery. And in the past few years, we've really expanded our programs to include safe surgery programs, training on the surgical safety checklist, our Clean Cut program, which aims to reduce surgical site infections, and then developing a headlight for low resource operating rooms that's fit for purpose, as well as organizing a lot of these sort of discussion forums and communities of learning to promote quality improvement practices, sharing of ideas, etc. So that's who we are. We love students.
Did you say you love students?
Yeah, we have there's student chapters that any students can join. It's called the Lifebox GSA, and they host their own events where they have speakers from all over the world come and share talks. So yeah.
And I assume this, but they have programs out not only in Ethiopia, but other countries around the world too?
That's correct. We have worked in, I think, over 114 countries.
Wow.
But we have a very small organizational footprint because we really believe strongly in working with local professional societies and having those sort of be the contacts on the ground. So a lot of our work is sort of conducted through anesthesia societies or surgical societies of different countries. But in Ethiopia, where we chose to do a deep dive about 5 years ago, we now have an in-country office and staff, and that's where I work. And it's a really bustling and rich office.
Yeah, sounds very exciting. We would like to know what sparked your interest in global surgery and specifically, well, global surgery and anti-neocolonialism.
Yeah. Well, I got my global health start as a Peace Corps volunteer. And at that time, I was a kid, basically. I had just turned 22. I had no idea. I hadn't traveled, like anything. And I was plopped in Ethiopia. So I, kind of took the experience for what it was. But I was very lucky that I sort of ended up in a place that was so enriching and whatnot. So I think a lot of my neocolonial ideas started to percolate then, even though, I mean, I didn't have a word to put to it, but all I knew was I was living like in this town, living a middle class type of lifestyle with all my sort of local community and friends, like basically not affiliated with any NGO or anything. So kind of living like an Ethiopian and seeing all these things like happen to the community. And I just kept being like, what? Like, really? Everything was just like so confusing and seemed like what was going on at the top and what was happening at the bottom was like people were functioning in totally different worlds. So those ideas kind of started to percolate in my head then, but it took me a long time to sort of put words to that and like understand what that meant and that other people had thought about this and whatnot. When it comes to global surgery, I did not think I was going to do surgery at all going into medical school. I thought I would do infectious disease or emergency medicine or, something that sort of very naturally fit into this world of global health. And then as a third year, when we do all our rotations, I fell in love with surgery. And I was like, oh no, what do I do? Like, I have to choose. Is it global health or do I want to do surgery? I'm going to have to give something up. And then lo and behold, you learn that in pretty much any field, you can engage in meaningful work internationally. But it took me a bit to come to that. And so I was very lucky to sort of be going through that process in medical school right around the time of like the Lancet Commission and Global Surge. And it was just very fortuitous time to sort of learn about all those organizations and those opportunities when I was making my career decisions. And so that's how I came to that field.
That it seems like in general in my readings that global surgery or surgery in global health is still a relatively kind of developing field. I think we all know about, malnutrition programs and malaria campaigns, vaccine campaigns. That's all very well known to us, regardless of where you live and how much you read the news. And so global surgery just seems so challenging. It seems so challenging to be able to do it correctly in the way that teaches the local providers, the local health systems, not teaches necessarily, but makes it, and it kind of promotes what they are already doing and makes it more sustainable, I guess. And the surgery that I know a lot about are kind of just these drop-in campaigns to do surgeries here and there. So I guess I'd be interested to hear like how do you like navigate them, because there's such different purposes, I guess, that they're achieving. Not to say you're not achieving anything by just dropping in and doing a few surgeries. It just doesn't help in the long term. So how do you see those programs?
Right. And I think, you know, kind of like we were talking about before with MSF and like humanitarian aid, I don't want to say that there's no role for surgical missions. There certainly, you know, you can't make the argument that no good is done by going to do, you know, glaucoma or cataract camps or hernia camps or something. There are people who need surgery. There's an unmet need that, you know, sort of backlog can be reduced in that way. But I just think we have to go in with open eyes about the ethical challenges that missions like that raise. And so by choosing to perform global surgery in that way, you are doing one part of good, which is meeting an unmet burden of surgical disease and treating individuals who need that operation. But it may come at the cost of engendering distrust or discontent with local providers who don't have as fancy of equipment and whose care is not free sometimes. It may exclude them or prevent them from learning new techniques that they could learn through participation in those camps. There may be complications down the line that those providers never know about because they're gone. And so everything has its own cost and benefit. And that's not how I will choose to practice global surgery in my career, but it's not an indictment of that sort of type of work altogether at all. I think that's kind of more of the old paradigm of global surgery. And we're much more moving towards like understanding that long-term collaborations, training surgical providers who live in low-income countries is much more high yield than just going for a couple weeks. So, you know, a lot of partnerships now are looking at how do we spend time on the ground? How do we train residents? How do we train mid-level providers? How do we actually build the systems? So, you know, global surgery is challenging because you don't just need a person and you don't just need a medication. You need a whole healthcare system. You need an operating room that works. You need autoclaves. You need nurses that are trained. You need running water. You need electricity. Ideally, you need ICU care. That doesn't happen in a lot of places. But when you're asking to, you know, promote access to safe, affordable, essential surgery, you're basically asking to have a healthy healthcare system, which involves a lot of investment. But just because it's hard doesn't mean we don't have to do it. So we have to start, you know, chomping away at the problem, looking at quality, looking at access, looking at provider training, looking at biomedical engineering, all these things that are so important. And we'll get there. You know, Rome wasn't built in a day. So.
Yeah, absolutely. Thank you for that. All right. So there's a question. A lot of student pre-medical mission trips are advertised as opportunities to gain new experiences, learn new cultures, learn about a new healthcare system, which ends up being very pro the visitor. And so how do you kind of respond to that? How do you feel about those opportunities? How can we navigate that a little bit better?
I think that's a challenging decision to make. And I can 100% understand the appeal of engaging in opportunities like that. I mean, it's so cool to go to a new place, experience a new culture, have people show you around, look at the hospital. that, is something that's very attractive to students, especially when they just they want a foot in the door, Um, but I guess what I would challenge the listeners is, what kind of introduction to global health do you want? Do you want a colonial introduction to global health? If you do, then, be a visitor that goes for 2 weeks and takes a tour of the hospital and takes other people's time, basically not contributing anything. And, that's how you get your experience. But know that that's going to shape the ideas you have in your head. That's going to shape your perspective on the work you want to do. And it might not make you the kind of practitioner that you want to be. So there's lots of ways to learn about healthcare systems. There's lots of ways we can access that in a less resource intensive way for our partners on the ground that are already working at like 200% capacity. So, go to webinars, watch documentaries, travel for fun. Go backpack through Guatemala. Like, you will experience the culture and the society. But you don't necessarily need to go as part of like a paid sort of medical volunteerism experience. And I really think we should be moving away from that and finding other ways to sort of introduce ourselves to what medical systems in other places look like.
Yeah, it's definitely a tricky subject, because I get that as a prior medical student and undergrad who really wanted to do well and really knew that she wanted to go into global health from the get-go, I mean, I have to admit, I of course participated in some of those things. And do I feel good about it? No. Was it necessary? No. I'm still doing what I want to do without having had that experience, and I can't say that it was that beneficial in the long run. So but I guess the difficult kind of challenge with that. But I think there are some good organizations out there. I would always take a moment to look at their mission statements, take a look at what their goal is for being within that country, and just take a deeper look rather than just looking at what they're offering you. Also take a look at what they're offering to the country that you are visiting, and that can be a nice way to, if you choose to participate, to make sure that at least you're doing a little bit of due diligence before you go.
Absolutely.
And then, yeah. Sorry, I'm spending a lot of time. So another question is, from your experiences, how do you view the impact that the ongoing advancements in technology have on anti-neocolonialism, and how do you see them working to aid in decolonizing global health?
Oh, okay, very good.
Mm-hmm.
I don't know, may not be techie enough to really thoroughly answer this question, but I do see advances in technology, at least in terms of communication, as really opening up this space. Particularly, I mean, not for us, but for our colleagues in other countries who previously didn't have the same access to the conversation that they do now. So, the fact that, and clearly the pandemic has had a huge impact on this as well. So the fact that we're now all on Twitter, on WhatsApp, on Zoom, it's very democratizing for a lot of our partners who won't spend $2,000 flying to Vienna for a 3-day conference, or can't get a visa somewhere. I think having more free and open communication and using technology to do that is only going to help to make it a more equal playing field.
Yeah, of the positives of COVID, I would agree. It's just been so fantastic to hear voices that you typically cannot hear, and it's incredible. Another question is, how do you think other health professionals besides physicians, so such as nurses, pharmacists, can contribute to global health and anti-neocolonialism?
Great question, and in a massive way. So if we think about everything that, I just talked about, it was mostly focused on physicians, but the need for this work to be done in the areas of nursing, pharmacy, biomedical engineering, respiratory therapy, all those ancillary services that make the hospital function and make patient care work is like so much more important and totally under recognized. So if people out there are sort of thinking like, hey, I want to be a pharmacist, but like, I don't know if that's really going to jive with this global health thing. Like, oh my God, yes. And if it doesn't exist like on the internet now, then you need to create it, because there is so much need for collaboration, training, and, strengthening of those professions that, I wish that I had mentioned that. And thank you for bringing it up.
Yeah, that was absolutely. I think when I started my MSF mission, one of the like crazy thing to me was like how many non-medical providers there were, or not doctors and nurses, and just how integral they were in helping provide the education and the support that we wouldn't know how to do, because there's tons of stuff that as a physician we don't have any clue what it entails. And it was hugely eye-opening. So yes, there's opportunities for everyone, not just physicians, absolutely. So what can we do so that we can hear perspectives from local organizations on what it will take to deconstruct narratives and structures that perpetuate colonialism and power dynamics in global health?
Great question. What I would suggest is try to join everything that you can. So there's a lot of organizations doing work in this space right now. And so if you can get on those listservs of, like, for example, Incision has chapters. Incision is a student group around focused on global surgery. And they have student chapters in like almost every country in the world. They're always holding events, webinars, etc. There's like the Lifebox GSA thing. All the organizations I know are like surgically focused, but there's lots of groups out there that are holding regular discussions in that space. So if you can just get on their listserv and start joining in on the webinars and hearing, that will be like really informative, I think, for someone who's shaping their perspectives right now.
Yeah, I would agree with that. And, everyone's opinion is valid, and we will only learn by listening and kind of being a part of the discussion. So always a great time to start. So I think that is the last question that I have. Amisha, do you want to take it away?
Yeah, sure. So, thank you so much, Dr. Starr and Dr. Park. It's always great to hear kind of professionals or global health leaders talk among themselves. I think we learn a lot from just hearing that conversation. For all of our attendees, if you are here for class credit, please be sure to fill out that Google form so that we're able to go ahead and send those off to professors, as well as if you haven't filled out the raffle yet, please do make sure to do that. And I guess going further, we look forward to kind of hosting you guys over this weekend. Tomorrow at 10 a.m. we'll be hosting our International Perspectives in Global Health panel. And then at 1 o'clock, we will be hearing our other keynote speaker, Dr. Jolie Kalinowski, about a key social determinant of health, stress and cardiovascular disease disparities in Black women. And then on Sunday, we have our networking session, which will be a World Cafe reflection. How can we engage in the decolonization of global health? So we're really looking forward to seeing all of you throughout this weekend. And thank you again for joining today.